First of all, there's some seats up here, so please don't be shy. We're going to have, it's going to be an exciting session. I want to introduce myself. I'm Dr. Bonnie Sanderson. I'm at Auburn University School of Nursing. And I'm really excited to see so many of an interest in this area, because it certainly is an interest in mine. We're still waiting for one of the speakers, Dr. Liu. But I'm assuming everybody was in the last session, correct? Okay. And I just want to kind of just kind of some of my impressions. I think this is great research, but what I kind of see it is the preventing early childhood obesity. But really, from the four speakers, the first two were focusing on the pregnancy one, and the other one's the early childhood. And to me, that's a kind of a continuous thing. So I want to open it up to questions to each of the thing. But if you want to introduce yourself first and just kind of your name again and your topic, I think we all know. You just touch it, I think.
I'm Melinda Southern. I'm with the LSU Health Sciences Center in New Orleans. And we did research in prepubertal children, 7 to 9 years of age, and tried to tie it all together in terms of some of the problems that these children inherited from what the first three speakers talked about.
Okay, so I'm Carol Amy Keith. I'm at Louisiana State University with an adjunct appointment at the Pennington Biomedical Research Center, and I'm interested in what women consume during pregnancy and pregnancy outcome. And I've worked in the area of breastfeeding and milk composition.
And Katie Kavanaugh from the University of Tennessee, also taking it into the first few months of life, breastfeeding or formula feeding or any other combination of things we hear about.
Okay, let's open it up for questions. Does anybody have a question? Okay, we got one.
I spoke briefly, just kind of your examination, your work based on whether you see mothers switching to a bottle feeding method as in lower income families, and if you see them switching to that, whether it be because they're single mother households and returning to work, or whatever the prevalence might be.
Yeah, and I'm glad you brought that up again. Thank you. We do know that being low income is a risk factor for not breastfeeding, and we think that some of that is because of the need, most likely, to return to work or school, possibly pretty early after delivery. So we do hear that moms don't even plan to try to breastfeed if they're going to go ahead and offer formula. So there have been a lot of initiatives to increase, say, moms who are working or who are participating in WIC to have access to a breast pump so that they can learn to use that and be ready for transitioning back into work or school. And so those are relatively new, maybe 4 or 5 years. We're just seeing some of the research come out from that. But there's definitely a relationship there.
Okay, did you have any? Okay.
Do you think that there would be any possibility of maybe women who can't breastfeed getting breast milk from other women who could donate, or would that even be sanitary a possibility, anything that we could look into?
You want me to take that? Okay. That's another hot button issue. We do have, right now, donor milk is preserved for infants in the NICU primarily, who we see can greatly benefit from that. And so when you talk about milk sharing outside of that, you do introduce, it's not very controlled because there's not necessarily a system in place for that. But if you think historically, that was the solution. If you couldn't breastfeed a child, then you got your sister or your cousin or whoever was able to be a wet nurse. So we suspect there are still activities like that occurring, but when you introduce things like the internet and sharing milk over the, from strangers and so on, there's some evidence to suggest that even donor milk comes in with some contamination and is processed when it's not processed because you're getting it from another source that isn't, that you don't know who they are. There's a higher risk for that. So was that your question?
Yeah,
Okay.
that's good.
It's a risk, I think.
Good morning, and thank you for your excellent presentations. I'm Rebecca Kelly with the University of Alabama. I'd like to know what the research is around workplace health promotion and really the opportunity not after a baby is born, but before a mother leaves the workplace. What are perhaps those best practices? And then once the mother returns, what are you seeing as some of those best practices in the workplace?
I think it's probably different from state to state. I mean, by law, there's supposed to be places for women to be able to breastfeed their infants, designated places, and we're not always seeing that. So start the discussion here. I'll let you take over.
Well, were you able to comment on, say, prenatal?
Well, I can tell you what's not happening in the United States, because y'all know it's not happening here. I mean, that's been actually shown in the literature. In other countries where it does happen, the health of the offspring is so much better. So, for example, in Switzerland, the mother takes a year off work and she's paid to breastfeed. Are y'all aware of that? So I just wanted to share that with you.
In the Scandinavian countries also.
And also in China too, there's a very good maternity leave policy, and women can leave their job and then come back later. First 6 months is the paid leave.
So a lot of women are, the place they can go is the bathroom.
FMLA only protects you in Louisiana 90 days. I'm not sure if the other states are different, but so even at the Louisiana State University, in that system, a pregnant woman can only take those 90 days, and then she's on FMLA. And if she doesn't then come back to work or make an arrangement so that her work gets done, then they can actually ask her to leave.
And yet, I think Tulane is this on? I think Tulane has a cutting edge program for supporting breastfeeding moms. Anyway, yeah. So there's a mix of things going on there. As far as prenatally, getting them prepared to maybe be in the healthy weight range to get pregnant. I guess preconceptive. I'm not as familiar with that literature. I don't know if anybody knows about workplace wellness programs that target getting moms ready with a healthy weight prior.
I think some of the hospitals that have baby-friendly programs do a lot more of that. And they're not handing out infant formula in those hospitals for those who aren't familiar with a baby-friendly hospital.
I cannot say too much about what is a worksite support for prenatal in terms of healthy weight, but I know CDC since 2006 and then other professional associations, they strongly recommend the interconceptional care or preconception care. So basically, preconception care is women who plan for pregnancy. They should see the physicians to check the health status and talk about how they can prepare for healthy pregnancy. So healthy weight is one of the things discussed. Yeah.
I had a question, and this has, because we're talking a little bit more about policy issues, and, as I said at the beginning, we have the pregnancy plus the post-pregnancy. But as far as the pre-pregnancy preparation and thinking about preventing childhood obesity, from the OBGYN physician perspective, is that brought, do you think that's brought in as strongly as it should, or do you think that they perceive that their primary focus is the health of the mother, and you think that the focus on the health of their future baby and prevention, if the message was broader? And I just want to hear your comments on those that look at that.
Yeah, I would say earlier I mentioned about timing is 2006, have a big recommendations or publications from CDC and WR, publications. But overall, people who use in preconception care is pretty low. It's about only 30%, or some states is 15% women use preconception care. So it's pretty low.
Question back there?
So, Ed Frangillo in South Carolina. The Bill and Melinda Gates Foundation funded a program called Alive and Thrive, a $77 million project, which is ending in December. And two of the countries they worked in Vietnam 2 years ago, partly because of the efforts of the project, they passed two laws, one to extend maternal leave, so it's now more like the Scandinavian countries, and the other to limit marketing of breast milk substitutes. Of course, formula companies tried to kill it off, and the U.S. government actually tried to kill it off. So that's part of our problem, is that we are not here or elsewhere endorsing the kinds of strategies that are being used there and in Bangladesh. Bangladesh in 5 years has moved its exclusive breastfeeding rate up dramatically because there was a social marketing campaign throughout the country, policy development, all kinds of efforts made sort of holistically at the country level. We're not doing that. We make it difficult for women to breastfeed by not letting them have time off from work. We make fun of them or ostracize them if they try to breastfeed in public. There's all these things that we're doing. Now we have data that you guys presented that suggests that we should promote breastfeeding in part because it might help prevent obesity. So how do we do that in the United States? On a large scale, like is being done in these 4 countries.
Okay, is this, I can't tell if this is working. It is, okay, good. That's an amazingly good question. I think one of the issues is the difference with in say Bangladesh. Those outcomes are very clear for breastfeeding because of infectious disease, respiratory illness, things like that. So it's something that can be seen pretty quickly, or the evidence is very very clear. So when we are working in a country where those are not typically the things that we hear about, and we're talking about a softer outcome of childhood obesity, I think it's a harder sell to show for us to promote breastfeeding and to fight the formula companies. I am all for fighting the formula companies for lots of reasons, but I think that one is a little bit difficult. I think when we talk about the choice to breastfeed, moms don't get the whole picture when they're asked whether they're going to breastfeed or not, or they think they're making an informed decision. But if they don't know about those risks of formula feeding and the benefits of breastfeeding, the full picture, I don't think that that's a true choice. So I'm not sure that that's happening everywhere. I'm sure there are other comments about that.
Well, it's only been in the last 2 years that the research has been conclusive. And I was fighting this with, some of the work we were trying to do. We were running weight management programs for women, and they had babies, and they were a captive audience. Had they had one child, then they were coming in to lose the post-pregnancy weight. And unfortunately, when we tried to make statements at scientific meetings that breastfeeding was clearly beneficial to prevent obesity and diabetes, there were 2 or 3 papers that were going against that the results were still mixed. And it was all methodology issues. I think you'll understand that whenever that happens. But gladly, like 2 years ago, this was resolved, and it's clear now that breastfeeding is beneficial to the prevention of obesity and diabetes. It's clear. So it's a new concept, and I think we just need time to put it into place in the social marketing. I work with a brilliant scientist. She knows her, Leanne Redman, over at PBRC, and she's doing work in obese pregnant women, and she's tackling a lot of this. And she's formed these mommy blogs. So let me tell you, this is a great place to go. The mommies have this huge social network of mommy blogs. She recruits from there. So if you guys are doing studies, that's where you can recruit from. You can get messages out to them. She uses these blogs for education, for social awareness. So I do think mommies today are smarter, and we have to embrace what they're using. And they're not necessarily listening to the scientists. They're listening to other mommies. Am I right?
And if I can share with you, there's a society that was formed about 3 decades ago, the International Society for Research in Human Milk and Lactation, and it meets every other year. It's meeting in South Carolina this fall. It will meet in on different continents in different countries, and I just want to share that with you because it's a society where people are totally dedicated to breastfeeding and defining breast milk composition and factors that go into this. So if you can Google it and find it. And maybe to come back to the question about, how can we change what's going on? Maybe a society like that's composed of an international population can help change things in places like the U.S. As you know, state by state we're different, and community by community we're different. So,
one of the points that hasn't come up, I think, is that breastfeeding tends to be more problematic for obese women in a number of ways in terms of onset of lactogenesis, sort of physical problems of breastfeeding. If you want to comment on that at all, Linda?
Yes, I did a paper looking at the by BMI status and the breastfeeding initiation and breastfeeding duration, and we do find, based on the population data, we find a mother who are obese, especially for African American women, because we did not find association among white. So that means African American women who are obese are less likely to initiate breastfeeding, and also for those who initiate it, they tend to have shorter durations too. Yeah. And then we cannot explain why among white women there's no associations. So that paper ended up trying to understand whether social cultural issues associated with the breastfeeding among African American women might be more predominant than white women. Yeah, because white women may in that group, they might be more prefer or treasure the breastfeeding, the benefits of breastfeeding. But for African American women, it's not. So back to what Dr. Frangeno, he just mentioned about, here, compared with the other countries, we still don't have maternal leave and other things. But I want to say, I've been working on breastfeeding for quite a few years. Number one, I want to say the United States has making a lot of progress in terms of, breastfeeding initiation. I was surprised, back 5 or 6 years ago, only 1 or 2 states, Oregon or the other states, who meet the initiation, Healthy People 2010 goal. And actually now you're looking at more than 15 states that reach initiation goal. So the problem is more like exclusive breastfeeding and also the duration, how long they breastfed. And I want to say a lot of policies and programs do, here in the United States help to make that progress. Like a week program support women who fed babies and provide pumps, and also the lactation, specialists, and then those baby-friendly hospitals, and even worksite support, and then education for mothers. So there's a lot of ways, can help to improve the breastfeeding rates.
We still have a long ways to go, though, if we're going to use breastfeeding to prevent obesity, because, as you just pointed out, it needs to be exclusive and it needs to be for long duration.
Mm-hmm.
And as I recall in the numbers that you were showing, Katie, you're not seeing the percentage of people feeding long enough and exclusively enough that we would need to really make much of a dent in the obesity epidemic with breastfeeding at this point.
So I just wanted to make a couple of comments. First of all, when we look at initiation, initiation can be for a very short duration, and so the statistics look good, but they may not really be meaningful. And then the other point I wanted to make is that when you look at different populations, and you mentioned the African Americans, it very often isn't the woman making the decision. It's the husband, the mother, the grandmother, the aunt who makes the decision as to whether this woman should. The new mother will be advised by other people, and she'll be influenced by it. And
Yeah. And I guess I wanted to kind of hear more from that too, is because there is a lot of influence from spouse, mothers, in-laws, and everything. And I think that's a lot of different cultures, not just African American. So I mean, that's part of the education too, is the mother may understand and willingness. So what are some of the interventions, or what are some of to address the family and culture influences of deciding to breastfeed specifically?
Do it.
They're not in the US.
Yeah, I think we'll find, that you have to get into the true relationship. You have to know what that relationship is. So, for example, with the father literature, fathers can be very influential and supportive in initiation and continuation of breastfeeding if the mom wants dad's advice. But if she doesn't, then it's not going to work at all. And so I think that's really part of it. You have to assess what those relationships are. And I think that they're very different in different situations. So I'm not so sure about what particular interventions have been helpful. But I think we have learned that we need to know going in.
And maybe follow up the timing, the preparation in the early pregnancy versus waiting till the time of birth and asking. I don't know what the literature says on that either, but I'm wondering, is it brought up earlier enough to help plant the seed?
yeah, and I can't answer that directly, but I'm as I think off the top of my head, if we have baby-friendly hospitals and they're doing the education, doing the prenatals, and the spouse or and family can be involved, that would be, it probably would make some headway.
So I actually would like to address that specifically, because what we have sort of found is that if you've been pregnant, as soon as you find out you're pregnant, you have a lot of decisions, and often you're kind of panicked about those decisions. And so taking that, we thought, well, let's talk to people before they're pregnant, and let's talk about what they think about breastfeeding and infant feeding. And so we've done some work with undergraduates, as guinea pigs, just the sort of this sense of what do they already know and what do they think about this. And we would like to go younger, but we haven't been able to get into school systems under 18 to talk about breastfeeding in our state. It's a little dicey. But we do know that the attitudes are better among men, actually, to support a future partner to breastfeed than women in Tennessee, in the undergraduate population. And so we think that we're learning just now, like, who do we need to be talking to? And we should be talking to them a lot before they're pregnant and on that sort of trajectory, because I think those decisions will be easier to make when you're fully informed going in, which comes along with the 50% unplanned pregnancy and all of those things. If you're dealing with an unexpected pregnancy, that makes it even harder to make some of these decisions. So I think that work is just now starting. And I will say we did the similar project in China and found, 'cause one of the questions was who should be helping you make these decisions. And in the US, very clearly, mom would be the one to make that decision. Maybe dad could be involved. And again, these are undergraduates. But in China, it was the grandparents. They were very, very important in making that decision. So I think we have a lot to learn about really targeting those interventions.
My name is Enari Hernandez from My name is Zenori Hernandez from Texas A&M University, and after hearing Dr. Frangillo, I'm trying to think a lot of things, and I'm gonna try to organize it. But so I work mostly with the school-age children, nutrition education, so a lot of behavioral changes, and we know now that knowledge is not enough, that we need to do a lot of things from the environmental point of view. We try to talk about portion sizes, self-regulation. So my first question is, when it comes to breastfeeding, I believe that many efforts have been done, especially with extension, to provide education to the moms. So they value more, we're trying to work on that, to value the benefits of breastfeeding. But then what he was saying is really an environmental support to value breastfeeding in terms of, I have to do my homework, but I don't know if there is a difference in self-regulation, thinking about obesity prevention in terms of if it's the same, like breastfeeding coming from here or from the bottle. I really would like to know if there is a difference, or as I said, I want to do my research, because I believe that when it comes, it could be breast milk, but if it comes from the bottle, we're kind of blocking the self-regulation process and the decisions from the babies since they're babies. And since we want to tackle this problem since early ages, I would like to know if you have an answer for that. And if there is a difference, I think we need to start doing more environmental type of strategies to value what is breastfeeding. I have a friend, and my sister is from Costa Rica, and you know, nowadays we have a lot of things to not be embarrassed about being in a restaurant, just put your thing and give the breast milk. But here I have another friend who is also from Costa Rica, and she asked me, I was in her kitchen, and she asked me, Tenori, are you okay with this? If I give like breast milk to my baby? I was like, of course, I mean, it's your baby, he needs that. So that's my question, like, it's something very basic, and I don't know what type of education we need to make that difference.
I'd love to start on that, but I don't want to hog everything. We do know very clearly that acculturation matters. You might come to this country with an attitude that breastfeeding is the norm, but by the time it's time to have a baby, you're getting the sense that that's really not. And so we do think that we do need to be doing, and we probably are doing some interventions with really buffering that effect. And so, but in the South, this is, you know, we're the ones who are most, we're most uncomfortable with breastfeeding in public. And so I think there's a lot of work to do again about what does that actually mean. So for example, in the undergraduates, I've asked them if they've witnessed a woman breastfeeding, and we have a yes, no, and an unsure. And I almost guarantee you that some of those who have said no probably have. They just have no idea that they have. And so there's a way to be modest. There's a way. There's times during infancy where the child learns how to pull the blanket off, which I'm not an advocate of blankets at all. But if you're using that and you feel like that's comfortable, one day that baby's going to learn how to get it off their face, and you're not going to know when that's going to happen. And so I would imagine that some of these exposures that people are thinking, oh, she just was right out there in front of me, probably weren't intentional for the most part from moms. So I think education about normal infant development is helpful. But you know, you're hitting on a point that people are sensitive to this, and it does change behavior. As far as the breast milk in the bottle, and anybody else?
Yeah, I can add some of my experience from China, you know, grew up there. So to me, when I was young, or even now, you know, I feel breastfeeding in public is just so norm, you know, for baby, for the women, for the mother. I see that often, you know, in China, women just, you know, breastfeeding other, you know, place. So here, it just definitely is a cultural norm. Here, it was treated, you know, more sexual organ, and then you could not public dispose it. So I think a change that cultural norm would definitely, you know, would be improve the breastfeeding rates. And I have a student who has MD degree from Nigeria, and when she had a baby in the United States, and then I saw her in the hospital, she never even asked that question, can I breastfeed now? She just breastfed. You know, so there was even you know, as she's my student, I never see her do that before. It was a little bit, you know, surprising to me, but it's just so nature. You know, so I think cultural norms is definitely plays a role here. And back to the question you asked about what's the difference between pumped milk and the breast milk, what's the benefits of that? I think it's the, you know, we do value that breast milk is the best, you know, provide the best nutrition for the babies because it's, you know, all the nutrients are different. So for women who, you know, in certain situations when they couldn't breastfeed, so we think breast milk is still better than the formula. And then we do have some people who do research to check, you know, what is that the impact of a suck, you know, the nipple, and how it's associated with the suck with the, you know, the other one who are bottle fed, whether it's good for, you know, respiratory, you know, function. And then they did notice the baby who breastfed, direct breastfed, you know, they have a better lung function in early life because that is like a breathing exercise. It's much harder to get the milk out from the breast versus from the pump, from the bottle. So overall, you know, all this evidence suggests that it's, you know, when it's possible, it's still best to have a direct, you know, breastfeeding. Yeah.
And just make one quick comment, because I think you'll find the occasional infant who has been breastfeeding and then if is offered breast milk in a bottle will find that easier because they don't have the work and then will actually refuse the breast and want the bottle. So that can happen.
Yeah, I was just going to comment also that everybody, I think, is assuming that breastfeeding is easy. And, you know, those of us who have breastfed, I think in the room know that even with the best help at the hospital, it's difficult. It's much easier just to make that decision at the hospital not to breastfeed. And the other point I wanted to bring out is that, let me ask a question. How many of, this is primarily students I see, how many of your mothers breastfed you? Can I ask that question? That's fabulous. Now ask us how many of our mothers breastfed us. So, you know, my mother, I'm a baby boomer, my mother was smoking cigarettes to keep her weight down and using, you know, she was Catholic, so she had one baby after the other. And because she didn't breastfeed, she did have one baby after the other because, you know, breastfeeding delays pregnancy. And so there's a theory out there that's really what started that cycle was during, you know, so that's some of the stigma and the culture that we're carrying forward in the South is that, you know, your grandmothers and great-grandmothers didn't breastfeed. And so that's how, that's the ones who are advising your mothers and your, so I think if you were breastfed, you're lucky because it's still lingering and it's still back from the 1960s that we're having to deal with it. And so I think awareness campaigns are needed. And I have students who have done work in this, and when they pull up the literature, it's clear, as they keep saying from the literature, that the husbands are not supporting it still. I mean, and the extended family are not either. And if they don't have life course training or skills from the first visit to the OBGYN is when I say they have to have it. And they have to have someone to walk them through it in the OBGYN office. And the OBGYN support this, don't you agree? I mean, they support some type of counseling, so.
And I think pretty generally when an infant is born these days, the infant is put to the breast, but if there's not support after that.
This is a great discussion. I'm Jen O'Neill from USC. I'm speaking also from personal experience. I'm glad you mentioned that breastfeeding is hard. It is. And that the importance of OBGYN help. And I think there's more that needs to be done from the medical side of things. One, I mean, from my work with children's physical activity, I know the health things. I know that. I didn't have my OBGYN talk with me about breastfeeding and the importance of it. Luckily, I had, at the hospital, there were several lactation consultants that worked with me. But that was more about the the mechanism, how to do it, and supporting me that way, as opposed to, oh, early on in my pregnancy, this is what's important, this is what you need to do. And another thing is, I think we need to make it easier for insurance company, or make it easier for mothers in terms of the insurance companies, because when I knew that I was going back to work, I'm like, I need a breast pump. And I would, through my health insurance, I had regular monthly calls with a nurse, and she would say, oh, it's covered 100% by the insurance company. No, it's not. It was like a one-sided manual pump that cost like $30. That was what was paid at 100%. And I had to spend several hours on the phone talking with different people and everything. And I ended up they only paid $80, and I had to pay the rest. And I could easily see a woman that, after that first phone call, well, I'm just giving up. I'm just going to have to, I'll breastfeed till I go back to work, and then that's it. So I think there's a lot that we need to do from the OBGYN side and the insurance. I don't know how to do that, but I definitely see the need.
I agree. Thank you.
I'm Amy Williams from University of Missouri, and this has been a wonderful discussion, and I want to thank you very much for your insight into this. I'm going to change gears here a little bit because I feel like there's lack of good news with obesity research, but recently some CDC data has come out that in that age group between 2 and 5, we have seen some improvements in childhood obesity, and I was just kind of wondering what your insights as to maybe the reasons behind that would be and what we can do to continue that trend.
That's if I can go first. That's actually conflicting, and I didn't have those slides today. But depending on what research study you look at, and the one study that showed that it was improving did not include all the states. Are y'all aware of that? It excluded a lot of states, and it was they didn't know quite how to handle the different ethnicities. So I think they just put them in a different pool or called them other. But what followed that were some great cohort studies that showed that the earlier the child was identified as obese, that it lingered in not just to childhood but all the way to obesity. And then another study that showed that minority preschoolers have the highest rates. The one study I showed at the very end where we showed benefits to NAPSAC. Are y'all familiar with NAPSAC? Nutrition and Physical Activity Self-Assessment. For child care centers, we did a randomized controlled trial, as I showed you, and I only showed you that data today, which was physical activity, but we have tremendous nutrition changes, too, in those facilities. Cheap program, 5 visits, easy to do, in child care centers. I think that, in the process of that, we identified that the female black preschool children were drinking the most soft drinks, for example, like 80% more than the other kids. Some things that we're going to be presenting at obesity this year, that they had the highest prevalence of obesity at that age. So I think there's a lot more to do with preschoolers, and I think that was misinformation that we got personally.
Back to breastfeeding. I'm David Baez from Mississippi State University. What evidence are y'all seeing for the importance of milk banks? I'm just recently moved to Mississippi State from UAB, from University of Alabama at Birmingham. There's a new human milk bank that's come up there, and there's one in Mississippi. I wonder, about pumping and sharing, and these are all processed, pasteurized milks that are being provided to mothers. This is a good practice, or maybe not so important? What do you say?
My primary familiarity with that is that it's those are used in the NICU. Mm-hmm. So for very low birth weight or extremely low birth weight infants.
Right.
And so right now, as I understand it, the demand is so great that there's really not a residual for moms who don't have sick babies,
yeah.
right? So
that's what I understand as well. I just am wondering, is there evidence that it makes that it's important for those babies.
For the sick
Yeah,
babies?
yeah, as opposed to just.
Yes, which is
effective
why
for
it
them.
is so much funneled to them, because the evidence is very strong for necrotizing enterocolitis, for reducing risk of developing that. That's the primary one that I think of. But yeah, it's expensive, but the costs are somewhat mitigated by it being donated.
Right.
So moms are not profiting from giving their milk, but the cost of processing and all of that and shipping and all.
So any good examples of ways to promote mothers providing that donation? Do y'all?
It's really not my area. Is Katie Bauer in here? Do you want to? She's a PhD student working in the NICU.
Yeah, and I actually, it's the evidence with, the donor milk isn't as strong as I think with using in premature infants, especially when you start to look at low birth weight versus very low birth weight, and the composition of the milk in terms of milk being donated tends to be more term milk versus preterm milk, and so the needs of those very low birth weight and low birth weight infants is vastly different than term infants. And also, too, I think a lot of what's happening is NICU's jumping on the bandwagon because of some research that's come out with that donor milk being as beneficial as the mother's actual own milk, whereas the research is actually, that I'm aware of, is showing that mother's own milk is still the ideal, but the support that mothers are receiving, which is what I'm kind of looking at for my dissertation, is very variable. And so the focus is kind of shifting as what is actually needing to be done. I don't know if that answers your question.
So can I ask, but between preterm formula provided in the hospital versus human milk, is that?
I think it's still, there's not really, from my understanding of the literature, it's not a concrete, this is better than this.
Mm.
It's a little bit better, but it's not as much as you would see with mother's own milk. So, but I think that's where the discrepancy starts to come in, is they're pushing the donor milk, and not necessarily, and some moms, we don't know if, since they're pushing the donor milk, are moms deciding not to breastfeed or provide their own milk. And so I think we just don't really know what's going on with that. And there's not enough that's been done so far.
She's right, and there's indirect literature showing that, of course, the nutrients pass from the mother, through the milk to the baby. That's pretty well documented. And even the new research on probiotics and the healthy bacteria, there was one study that showed that transfers to the baby, and the baby that had the good bacteria had less colic. That was one study, but I thought it was amazing. So there's a question of, if the mother was healthy during pregnancy and had a healthy pregnancy, and then she's breastfeeding, then all of her decisions are passing to the baby. But if it's somebody else's, how healthy were they? And that's why you'd never want to compensate them as well, so, because that's a tricky question. It's funny, but of course we're going to have a study to show that, that. I call them the DUS studies.
So I wanted to raise an issue, picking up on something Melinda said before. When the obesity epidemics sort of first came in place, the pediatric societies in the U.S. and Canada and the dietetic associations were very clear about, they didn't want to see any thinking about interventions below 24 months, that should be protected. So now we have data telling us that there's a link between early weight status or weight gain and later. Elaine Traveris at Harvard, I think it was about 4 years ago, I've lost track, wrote a paper, one of these papers making this link, where they left the implication that we should be doing early screening and then acting on that. And the editor of Pediatric and Adolescent Medicine asked me to write an editorial, which I do with Michelle Lample, who's down the street here, at Emory, just talking about the potential harms and what we would need to know to be able to do this. So the question I wanted to raise is that we've been talking today in this session about breastfeeding as sort of a way of dealing with this, but there's other things that people could be trying to do, some of which are population-based approaches, and some of which are very clinical, focusing on particular infants and intervening, and it seems like that's really risky. What do you think about that, and where we should be going to try to make sure we don't induce harm?
there are different ways to answer this, but I come back to the evidence that we have. First of all, that if a woman is obese when she goes into pregnancy, she's setting that child up from day one for that trajectory. So I guess I would just say perhaps our efforts should be better spent trying to educate the women and the obstetricians and healthcare providers who are dealing with them when possible, when it's a planned pregnancy, and maybe, I know a lot of pregnancies aren't planned, but to take care of the pre-pregnancy weight, because the evidence is there.
But if they're already damaged and they're between birth and 24, a lot of these mothers are putting them in daycare centers. So I just want to add to that. These working moms are not taking care of the children. And when we measured the physical activity of the children before we did the intervention, they spent 83% of their time in sedentary pursuits. And this was birth to 5 years of age. So what these interventions do is it shows them not to put them in a high chair in front of the TV, not to stick them in playpens. It adds movable toys inside and out. It promotes outdoor play, which has numerous benefits. I could have lectured about that all day. The benefits of outdoor play, just D3 and everything else that goes along with it. So I think that the medical community, clearly needs to embrace this, the OBGYNs and so on and so forth, but so do the schools. And we already know that the school systems, when they get to school age, are really limiting the amount of physical activity they can engage in. And y'all all know the work of Michelle Obama to try to get the school lunches in place. So I think, you can't really just target all prevention. It also has to be what happens when the child is there. What I showed today shows that you might be able to deprogram these children. If they're physically active, you can alter their metabolism. If I didn't present the nutrition data, but if their nutrition is beneficial, the cascade of that epigenetically, y'all heard Claude Bouchard yesterday, is phenomenal. So we should really try all sectors of society, and I know that you'll hear this all the time, and if we could just have a coordinated effort, that would be my dream, is that everyone would just work together and not against each other, and not in these vacuums.
And if we've made headway in terms of the foods that are being provided at these child care centers, then why can't we take the next step and go in and educate and let them know that the children need to be physically active? I mean, just having inexpensive balls there for them to throw and chase would go a long way towards that.
We had a tremendous change in sugary beverages being given at the center, huge change, and them being served water for thirst and having fruit for snack. Those three things, really simple changes. I think it would go a long way.
I think we've only got about 5 more minutes, but I guess you have a question
Could I
here.
just address quick? I think we also do need to be very careful to not identify kids who are growing fast, but that's normal, right? So we have to be able to figure out the kids who should be on that trajectory, right, and intervene, because I'm sure that most parents would interpret that their baby is that baby, right? So figuring out how to do that well, I think, is a big challenge. And the underweight also, to watch the underweight.
The point I was, trying to raise is that there's a big difference between taking the kind of approach Melinda was just talking about, which is all children will benefit by having access to objects that will stimulate their play and changing the environment out. That's very different than starting to single out particular children on the basis of they happen to show a very fast trajectory and saying, okay, you're at risk and therefore you will be labeled and we will now act by giving you the magic pill or whatever it is that's going to be done.
And medically, between 0 to 24 months, we just don't have enough information to make those decisions. I'll tell you, we're just now learning about prepubertal. And, what happens if a child goes in and has high inflammation and they have asthma? We don't know. We don't know what that means today. They're put on steroids. What do steroids do, to the metabolism? So to back it up that far, 0 to 24, it really has to be about the family behaviors, the mom's decisions and her behaviors, and the environment that the child is going to be in. And unfortunately, in this economy, the mother's working. So I think, you know, stay-at-home moms, I mean, they're the ones who are blogging, am I right? I mean, they're baking their own baby food. They're doing everything right because they have time and they have the income for it. But, you know, all these other moms are working and it's hard. So we just have to make it easy for mamas. That's my last message today.
Well, and actually,
Easy for moms.
yeah, we have one more question, but also after that, what I would like to do, and I don't want to put you on the spot, but is just have just a brief thing of, because we do have a lot of students here and a lot of things to answer is, you know, the one question you think that needs to be answered in the next 20 years. Oh, dear. But she had one, you had a question?
Yeah, I may be a bit of an outlier here. I come from the humanities, and it seems to me that is a piece that's not being addressed here. And I guess this gets back to the breastfeeding. Like, how can we inspire women to breastfeed? What we need to be seeing more images of women breastfeeding in the media, in television and film, and to make it like a social norm and an attractive, positive thing to happen. And so I've been reading a little bit about what constitutes persuasive, what are effective persuasive messages, and giving information, from what I read, is not the most effective way to change people's behavior. But if it seems like it's socially cool or sexy or whatever, and everyone's doing it, that is more persuasive. So, I don't know, maybe that's something to think about. Thanks.
Mm-hmm. So it's not an easy answer. Okay.
You're going to go on this one?
Okay.
What's your question? Next 20 years?
Yeah, maybe 10, maybe 10. Just one simple, I mean, it doesn't have to be, we won't record it.
I would just keep on working the areas. I think there's a tons of questions to be answered, you know, to help women to have healthy weight during pregnancies and also prevent this intergenerational linkage, you know,
I actually agree. I think it's the changing social norms especially in the Southeast, and how do we do that?
And how are we going to break through public and institutional barriers?
Mine's really easy. I want to study if putting recess back in school will prevent childhood obesity. And this is how much we need, and I say this every time I lecture. The children don't need 1 hour minimally a day. That's what the literature shows in all children, is the minimum is 1 hour a day. But if they're already obese, they need 2 hours minimally, or they're never going to have the metabolic improvements to their system to be able to grow into that weight. And I don't mean grow into that weight as simple as they get taller, as in get their organs working right, so that the normal hormonal changes that would happen through growth and development happen. So minimally 3 hours, 3 hours is what I'd want. 15 minutes in the morning is required, 30 minutes at lunch required, 15 minutes in the afternoon required. Because there are studies that show that if children sit in their desk all day, they're less likely to be physically active at home. So the flip side is true. The schools are always trying to say, what's the parents' responsibility to give them physical activity? I'm going to be 59 years old. I had 15 minutes of recess in the morning, 30 minutes at lunch, and 15 in the afternoon, and I'm not too dumb. So I think we can do it, and I would like to see those studies. I wish we could randomize control those studies. You know, I mean, I'm pretty dumb. I'm from Houma, Louisiana. I'm a little Cajun girl. I'll tell y'all that. But if we could do a randomized trial of that ethically, some kind of way, I promise you would see tremendous changes in this obesity epidemic. Recess.
I just want to add, you know, the best way is probably 10 minutes every 50 minutes class.
That too.
That's what I did when I grew up.
Yeah, that's what they do in Europe, and she's right, but that'll be harder to implement.
Okay, you had one?
I think it's really important what you're talking about, but until we pair studies that are showing educational outcomes, we're not going to change school policy. So we've got to think about how
We have it.
We've got some, but we don't
have a lot. We have a lot of studies showing that fit kids are smarter,
I know.
and physically active kids are smarter.
We've got to look at how we get school boards, school principals, who are often coaches coaches and come from
They
an
don't-
environment of supporting physical activity.
I don't want to end on a negative note, but those individuals do not trust the scientists. So it's a bigger problem in that we have to be better about communicating our scientific results to the public. And the media does not help us. It's very, very difficult. So if anybody in the media out there, you know, we need help making sure that what's sent out is accurate. And I think then they'll start believing the studies more. But that's a new problem.
Yeah, and again, since we're out of time, I just wanted to, first of all, thank our presenters for both what they did and the discussion here. Thank you. And then for the future generation is, even though they're simple answers, it's not simple to implement. And so that's, you know, the implementation is the real challenge. So I guess that's, to me, one of the things that we need to get a lot of interdisciplinary work. There's a lot of disciplines that need to be involved in this. And so thank you for attending, and good luck.